Sorry, my poll sort of disappeared for a minute. Sorry.
Oh, you're good.
Can you see it?
Thank you. Unless people are filling it out. Like most more general public. Great. Hello, everyone. My name is Jennifer Smith, and I am the Community Liaison at Klamath Hospice and Palliative Care, a member of the Oregon nonprofit Hospice Alliance. This three-part series titled Hospice Care Unveiled, a roadmap to advance healthcare planning, end-of-life care, and grief is hosted by Oregon nonprofit Hospice Alliance, also known as ONA, in collaboration with its member hospices. ONA, one second. ONA brings community-based nonprofit hospices together to provide the best care possible for patients and families facing end of life. As nonprofit hospices, we are mission-driven and heart-centered in our care, prioritizing people over profits. You can learn more about our work on our website, onanetwork.org. And sign up for our email list to make sure you hear more about future offerings for the public. Today's talk is about POLST and advanced directives. We have two more talks coming up this month, one on the 18th that will be a Hospice Care 101 featuring a panel, and one on the 25th with our bereavement specialist and on anticipatory grief. You can still sign up for those by going to our homepage. Before I introduce our presenter today, I'll go over just a few technical details. Lori Kaiser from the Oregon Nonprofit Hospice Alliance is here with us today and will be our tech host. Hello, Lori, and thank you. If you're having issues with Zoom, please message her directly using the chat. We want to make sure there's ample time for questions and discussion. Please hold your questions until the end or put them in the chat box. Please do keep in mind that this presentation is being recorded and will be posted online. A recording will be available to you afterwards and will be emailed to all who registered for this event. Also, please click closed caption if you would like to use it. Now, I'm very pleased to introduce our guest speaker for today. Dr. Holly Montjoy has been a family physician for the last 12 years in Klamath County. She rejoins Klamath Hospice and Palliative Care as our medical director within the last year. Now, I would like to pass it off to Dr. Holly Montjoy.
Hi, thank you. I'm just going to get my screen up. Can everybody hear me? Give me a thumbs up. All right. Okay, so I'm Dr. Montjoy.
Holly,
and
can I pause you for just 1 second?
Yeah.
I want to make sure you're pinned and spotlighted so that we.
Oh, here we go. Yep.
Excuse me.
How's that?
Thank you. Good.
Much better. I told you I would get nervous and forget to do something.
No worries.
All right, so let's try this again. I am
Perfect.
in fact Holly Montjoy, and I'm now spotlighted. And it is in fact 2024, which I keep messing up on all my documentation. So I am a family physician by training, jack of all trades, master of none. Dr. Galis can probably vouch for that. This is my Southern accent from North Carolina, not my Southern Oregon accent. So if you hear the twang, just know that's not everybody in Klamath Falls. I do have a couple of disclosures today. One is that I do own a voting share in our local CCO. I'll also disclose that first and foremost, I am very happily married and a mom to these two incredibly wild children who bring my home value down every day, but my sense of purpose up in every moment. And then also, along my own personal wellness and professional journey, I acknowledge that I believe myself to be a work of art and very much also a work in progress. So I do ask for your grace today with this presentation. I may mess up, and as Lori reminded me earlier, that just makes us human. So here we go. My agenda for today, I'm going to introduce these topics. We'll go through our objectives. We're going to go through the POLST form first, not because it's the most important, and I'll get to that in a little bit. We're going to talk about an advanced directive, followed by just a review of the key points or pearls, as we like to say in medicine. And then we'll open it up for any questions or discussion that you may have. Jennifer said, if you have questions, you can put them into the chat box. I can't see that in live time. So what we'll do is we'll track those questions and we'll circle back around to those at the end. There will be a moment though where I will pause during the presentation a couple times, just mainly around medical knowledge type things, and let you ask those questions in real time, just because I feel like that's important and we may not remember to do that later. So here are our objectives. I want to introduce the idea and reinforce the importance of advanced care planning, describe for you the differences because there are very distinct differences in the POLST form and an advanced directive. We're going to go over the POLST form in great detail. We're also going to review the advanced directive in detail. And then I hope I can answer any burning questions that you don't have. If I can't answer them, we will take them down and find someone who can and reply back. So this is actually from my heart to you. I believe that the opportunity to plan for the end of your life is a gift. Having gone through losing family members and experiencing some of this myself, I believe that planning is a kindness that you can do for yourself and your loved ones. And taken from some of the literature that I've read and been involved with, particularly a book called The Sacred Art of Dying, I believe that it affords you another opportunity as well, one that we don't do as commonly in modern times, which is to use the conversations around advanced care planning and around death to inform and reflect upon the lives that we are currently living. But needless to say, these are not easy conversations, and oftentimes they're not ones we really want to have. The POLST form, let's start here. So the POLST form stands for Portable Orders for Life-Sustaining Treatment. Henceforth, I am going to say POLST just because it's easier, but that is what it stands for. It used to notably stand for Physician Orders for Life-Sustaining Treatment, and it no longer stands for that for a few reasons. To be compatible with other states in how they represent this form, but also to represent that it doesn't have to be a physician that signs this order. Order being the key term next, and we'll talk about that and why that's important. So, POLST versus an advanced directive. An advanced directive is a legal document. A POLST form is a medical order and a medical document. Where would you find a POLST form? You can find a POLST form usually at your clinician's office or in the hospital. You probably, if you're admitted to the hospital, going to be strongly encouraged. You can't be made to fill one out, but you will be strongly encouraged to complete one during your hospital stay because it is a medical order. Advanced directives are for everybody. I myself should have an advanced directive. Do I? I'm not going to answer that maybe because I'm trying to lead by example. But should I? Absolutely. A POLST form, however, is not necessarily intended for everyone. In fact, and it specifies clearly on the form that a POLST form is for people with serious medical illnesses because, again, circling back, a POLST form is a medical order. And when I pull up the POLST form for you to view, I can show you what I mean by that. POLST form is for emergencies, and you're going to see that too when you see the text. And it is typically filled out in conjunction with a medical provider. That being that it really is something that should be informed by a clinician with experience in counseling you on that order. An advanced directive deals more with subacute to long-term care decision making, and we're going to go through that in more detail later, so don't feel like I'm not covering that now, because I'm going to pull it back up in a little bit. You can self-administer an advanced directive, but I do encourage you to be informed by by a clinician, or at least someone who you feel like knows what they're talking about, because there are things on there that you just don't want to default select, in my opinion. Both of these documents and directives are patient-centered. They should be about you, and they should be about what you want. And that's why planning is so important. It's like that saying, you don't want to learn to swim when you're drowning. You don't ideally want to be making these decisions when it may be too late to do so. And if you don't have medical capacity, or if you're sick enough that you can't make these decisions for yourself, then you risk not having your true wishes be honored. And that's why this really is so important. Both of these, and hear me when I say this, both of these things can be changed. So it may be a little harder to change your healthcare proxy on your advanced directive, which we'll get to in a little bit. But for the POLST form, for instance, if you select something such as do not resuscitate, and you end up in the hospital and you don't want that anymore, you can just say that, okay? And that you, with a clear mind, can override that decision, as can your healthcare proxy. So these are guides, but they can be altered. I do recommend, and obviously a little bit of a bias as a continuing practice primary care provider, I do recommend that you discuss both with your PCP, and I recommend having both in your medical record. But while we're on the topic of storage, and just so I don't forget, an advanced directive could be stored at home, in your medical record, or with your will. So some people refer to it as a living will. Your POLST form typically is stored at home, and then also in your medical record, as well as a state registry should you opt for that. And actually you have to opt out of having it shared with the registry. And this is nice. This is, in my anecdotal experience, relatively new, that one could enter the ER and they would be able to access your POLST form from online from the registry, but important nonetheless. Some of my patients, because I now practice with hospice and palliative care, and most of my patients have a POLST form, some of my patients don't want to put it on the refrigerator, which is where we sometimes counsel patients to have it. Would I want my POLST form on the refrigerator? Probably not. It's not like a chipper reminder of what you bought at the grocery store this week. And so what I've counseled people sometimes is to have an alternative sign on the refrigerator that says, hey, my POLST is in the drawer right next to the refrigerator. So if having your POLST form visible to you is triggering, or otherwise, if you don't want that, there's an alternative, but it should be easily accessible. Okay, let's dive into the POLST form. So here's our map. We're going to start with patient information, cardiopulmonary resuscitation, medical interventions, discussion participants, and attestations. And some of these things have changed over the last year, and so it'll be important to review those. So this is pretty basic. This is the top part of the POLST form, which is going to ask for your name, your date of birth, and your address, etc. One thing I want to key you into, though, is this small line above patient's name, which says, follow these medical orders until orders change. Remember, we said they could change. Any section not completed implies full treatment for that section. So you do want to complete this in its entirety, or the default will be full treatment. All right, next are sections A and B. Cardiopulmonary resuscitation, or CPR, is at the top. There's attempt resuscitation, do not attempt resuscitation. And the biggest thing here about section A, which we're going to tackle first, is that it specifies unresponsive, pulseless, and not breathing. That is what most consider a natural death: unresponsive, pulseless, and not breathing. And that's important because this doesn't take into account, let's say, if you are in the hospital and you have an unstable heart rhythm, but you have a pulse and you are responding. This, in that situation, this doesn't tackle that situation. Okay. So this was on my heart to share with you today because it's something I've been thinking about a lot. This was an article that was released by Harvard a few years ago in 2016 that was called How Doctors Die. And I personally have practiced ambulatory medicine in the clinic. I've practiced a lot in the hospital, including in an open ICU. I was there in the ICU for the COVID pandemic when many people, when the vaccine wasn't available and many people were on ventilators and shared ventilators and all kinds of crazy stuff. And what I want to reiterate with this study, just for you to consider, is that this analysis confirms what we've long speculated, which is that physicians who are more likely to have, and I'm having trouble seeing that side. Hold on, let me change my box over here. Okay. That physicians who are more likely to have firsthand experience with the burdens and futility of end-of-life care are less likely to have surgery or to be admitted to the ICU during the last 6 months of life or to die in the hospital. That is, doctors who have been there and been through it, they want less surgery, they want less time in the ICU, and they don't want to die in the hospital. And so the question I bring back around, and this is gonna be like, I'm just gonna keep repeating this just so it really comes home, is how do you make this happen for you, or whatever it is that you want, which may not be what I want, and that's why we're individual people and the world needs all of us, but how do you make what you want happen? And you plan. Everybody knows this guy. So he says estate plan in 15 minutes could save you 15% or more of your estate. And I'm just going to argue that the same rings true for your end of life decisions. You really do want to take this seriously and you really do want to think about it ahead of time. So back to cardiopulmonary resuscitation. I don't mean to be graphic here, but I think it's important that people understand what that means. And that is that in that situation, we are, as physicians and as your resuscitation team, going to provide chest compressions at 100 to 120 compressions per minute. So, 2 compressions every second, and at least 2 inches in depth. And frequently that results in tissue damage. So frequently that will result in broken ribs, damage to the lungs and to the heart. If that is, if you're in a position in your life where that risk is something that you want to take in order to be fully resuscitated, that's you. That is your medical decision, and I support that, as should your healthcare providers. But it's worth considering that that might not be what you want for you or your family. So just some facts about CPR in general. I told you about the physical component. One thing that in the hospital that we try to counsel patients on is that sometimes resuscitation can be successful with just cardiac resuscitation, but usually you are going to need to spend some time on a ventilator. Usually, not always, but usually if you undergo that level of resuscitation. Pharmacologically, we're using medications to try to slow down heart arrhythmias and otherwise boost your adrenaline during those times. And then I just talked about respiratory support. Survival from CPR is really variable. It's higher in the hospital than it is outside of the hospital. Years ago, and I actually don't know if this is still true or not, but years ago, Seattle was actually had the highest rates of out of hospital survival from CPR, and it was because of their intricate network of EMS services. But out of the hospital, far less likely to survive, and more notably, out of the hospital, far less likely to survive to discharge. So even if a viable heart rhythm is recovered and you make it to the hospital, you'd be less likely to make it out of the ICU and onto a meaningful life. In the hospital, that's different, and it's very different also for when you undergo procedures or things that might elicit some of this, as opposed to it being your underlying physiology or like heart problems and stuff like that. Things to consider when you're making these decisions would be your age, your pre-existing conditions, current quality of life, neurologic status of you or for your relatives for whom you may be helping make these decisions, and then the time of resuscitation. Why is the time of resuscitation important? Well, years ago, we learned as clinicians that we should be bringing families into these conversations and into these procedure rooms and to the ER, et cetera, when we are performing resuscitation. So it would not be uncommon that if you or your loved one were undergoing resuscitation, that the family would be invited in to inform how the medical team should continue or not during that process. And it's actually been shown to honor more decisions that were felt patient-centered, and also to reduce PTSD for all those involved, particularly family members. And then the belief section, I just put natural death versus resuscitation, and that's really just more of an acknowledgement that everybody feels differently about these things. And that's perfectly fine. And that's, again, why we get to be our unique selves. So the second part of the POLST form is section B, and this is one that's a little bit more complicated. This is medical interventions. The first is comfort measures only. And I won't read through all of the paragraph, but I'll go to the bold section which says patient prefers no transfer to the hospital for life-sustaining treatments, transfer if comfort needs cannot be met in current location. I think one good example of this is patients who are on hospice are very commonly comfort measures only. However, if we had a patient on hospice who fell and, let's say, broke their hip and were really painful, needed that bone reset, that person would still go to the hospital and could still be comfort measures only. So that's sort of an exception there. Selective treatment generally is you don't want to be in the ICU, you don't want the big IVs, you don't want to be intubated, but you'd be open to having a regular IV, fluids, IV antibiotics, and a mask for breathing, whether that be just a regular mask or something like a CPAP, which many of us are familiar with. This one, generally speaking, if you are pretty sick, you are going to want to go to the hospital. You've indicated that you want to go to the hospital, but generally you would not want to be in the ICU. And then the last one is full treatment, which is kind of, the general default, which is do everything you can, including ICU stay. Previously, you could actually pick that you were a CPR, attempt resuscitation, and comfort measures only, which those really didn't align for emergency care providers, EMS, and in the ER. And so now, if you are CPR, generally you are selective or full treatment. They won't allow you to pick two things now that don't align together, which makes sense in some ways, I think. I think I will pause here and just see if anybody has any, let me go back, if anybody has any questions about kind of the nitty gritty of the medical interventions or CPR.
Polly, it's Lori. I don't see any questions in the chat. If somebody does have a question, they can unmute themselves and ask the question.
Okay, can you hear me, Lori?
Yes, I can hear you very well.
Okay, all right, I'm gonna keep going then.
Okay.
Okay, so the next section is who the POLST was discussed with. So if you filled out a POLST in the past, section C might have been about feeding tubes. That's no longer on the POLST form. One reason it's no longer on the POLST form is because generally speaking, it is not a great medical intervention. Frankly, there are reasons to consider a feeding tube. There are lots of reasons to not. And so it's no longer included. But what is included is this who you discuss the POLST form with. And this is required. And this is because the state of Oregon, really, and your healthcare team wants to be sure that you have shared your wishes or that your wishes are, being witnessed by your healthcare advocates. Just that you have proper representation in this process. And then this is the last part of the POLST, and this will be where you or a representative will sign. And then your medical provider will sign below. The license number and phone number for the medical provider is no longer required. So just a signature and the date, which is important. Here's the back of the POLST form. So I show you this, and I am going to read through some of this. This is more administrative than anything else, but a POLST is always voluntary, cannot be required. So know your rights there. It's a medical order for people, remember what we said, with serious illness or frailty. It's an expression of wishes for emergency treatment. It is not an advance directive. So when I admit people to the hospital and I ask them about their code status, would you want to be resuscitated if your heart were to stop? People will commonly say to me, I don't want to be on life support for a long period of time. That's not a POLST form. You can't, that's not designated on this. However, that would be something that would be a must for your healthcare proxy to know, and also could be better delineated on your advance directive. So really can use both of these tools together, but the POLST is not where you find that. You have an opportunity here to provide your emergency contact. This is not, again, legal for a healthcare proxy, but we're going to get there. And then there's things about the registry there. Directions for healthcare professionals pretty much says that we need to make a note that we've talked to you about these things if we're filling this form out. And I had to throw in some lame mom jokes. How do you organize a space party? You plan it. All right, there were a couple smiles out there. Thank you for tolerating me today. I've only had 4 cups of coffee in preparation. All right, advance directive. Let's go there. So this is actually from someone who knows what they're talking about. This quote came from Mayo. It says, by planning ahead, you can get the medical care you want, avoid unnecessary suffering, and relieve caregivers of decision-making burdens during moments of crisis or grief. You also help reduce confusion or disagreement about the choices you would want people to make on your behalf. And these really can be very divisive conversations, particularly among family members. And frankly, it's really sad to see that happen, especially when that family, had been so close before. So just another plug. Here's the meat of the advance directive. This is just one example. Typically, an advance directive is going to be a few pages in length. They are free. You can find the forms online. I've been told you can buy them from Staples, which would theoretically be a waste of money, but if you don't have a printer and you can't find them online, then I don't think that they're very expensive. And you can get them from other healthcare form places. We provide them at our primary care clinic, so a lot of opportunity to have these. And they can differ on the verbiage, but generally they're pretty similar across states and what have you. So they give you these different scenarios. If you see listed under A, it says terminal condition. The next bullet or the next letter might be something like a life-limiting condition or a serious condition, but not terminal. Regardless, this is the general flow of what an advanced directive is going to look like. It will define the condition that we're talking about, so that in this situation, terminal condition defined as an illness that cannot be cured or reversed, and one that my healthcare providers believe would result in my death within 6 months. And then below, you have 4 different options, and you're going to have these same options in one iteration or the other for each condition. The first one says, I would want to try things to sustain my life, including things like feeding tubes, fluids, breathing machines. So you can see that there's a little bit of redundancy, but that this is also a more complete document than the POLST form. Each one below is going to be kind of a scaled back version of the first. So the second one, I would want to sustain my life with artificial feeding and hydration, but I would not want to sustain my life with a breathing machine. Let's say you don't know for sure which of those you want. You could either talk to a healthcare professional and your family members or healthcare proxy about and get their insight to try to make that decision. Or you can have a very open conversation with your healthcare proxy or your healthcare representative, healthcare alternative, however you want to put it. And you could mark the bottom one that you want that person to be able to decide for you after they talk to the treating team. And so I'm going to pause here just for a second to see if anybody has any questions about artificial feeding or life support.
I have a question about DNR status.
Okay.
Many years ago, I worked in healthcare, and at that time, 35 years ago, if someone was officially had DNR status, it's only supposed to mean that you don't get resuscitated, but in practice, it meant that that patient's life was considered less urgent and they would get, care that they would want on a less timely basis. They'd be, kind of put to the bottom of the list of priorities. So that's a concern that I have now about being in the DNR status. Is this like from 35 years ago, the case? Is it still sort of like that, or is that no longer the case?
It shouldn't be the case. And I don't think I can't speak to all facilities and all providers, but I do think that the culture is different. However, you may, if you have a similar condition to the person next door in the hospital and they're full code and you are not full code, a DNR, they're full code, you're DNR. Might you be moved to a different part of the hospital potentially because of that? I want to say that, that could honestly be possible only because if someone needs cardiac resuscitation, they need that resuscitation team present. And so, maybe you would be moved to a progressive unit rather than the ICU, even with a similar condition. And that perception could be that you're receiving substandard or less care. The reality, in my very humble opinion, is that it would be more of a resource move. It would just be the hospital and you acknowledging that, if your heart stops, you're allowing a natural death, whereas this other person wants that whole team immediately available, and that's where they are available. That's where I see that going. But it should not ever mean substandard treatment for the things that you still want treated.
Okay.
Dr. Holly, we have one more question from Chris. And they said, please describe artificial feeding.
Yeah, so thank you. Thank you for your questions. I'm glad to know that people are still awake. Yeah, artificial feeding. So if you cannot feed yourself, there are several ways to provide you nutrition. One would be to put a tube down through your nose. It's an NG tube, a nasogastric tube. So through your nose to your stomach, that's the nasogastric. And to hook that tube then up to a pump, which pumps food into your stomach. And that nutrition is similar to like Ensure or Boost. That's considered very temporary, but does happen, particularly if you're on a breathing machine for more than 3 to 5 days. You usually would need that to be initiated for healing and so forth. Or if you've had a stroke that impacts your swallow, that's another very common example of when you might need that. If those conditions are felt to continue forward and you still cannot adequately feed yourself past several days, I want to say maybe a week to 2 weeks, then you would need to move toward a feeding tube, which is called a PEG tube, but that is a surgery where you have a tube inserted into your stomach and you are fed via that tube on a pump and not through your nose. And so that's a more permanent solution to that. And the more common in things like patients who have ALS, um, or maybe have had esophageal cancer and radiation to the esophagus, where they're going to have a permanent issue with nutrition. That being said, when you're considering artificial nutrition, I really want you to consider quality of life. If you or a loved one has had a stroke and are expecting some level of recovery from that, then it would make sense, in my opinion, to move forward with that artificial feeding for some period of time, do some rehabilitation, try to recover some of that ability to swallow, and then move forward in that direction. However, some of the controversy comes in when we're talking about patients who have advanced dementia, who have lost their appetite and truly do not want or desire to take in anything orally. In those situations, it is true that those patients are not usually going to be able to sustain themselves from a nutrition standpoint, but generally in the medical society, it is not felt to be a strong quality of life um, boost to have a feeding tube in those situations.
And then, thank you, Dr. Holly. There was just a comment from Megan that goes back to your POLST presentation. Do you want to hold that till the end or address it now?
Sure. I'm fine with anything. We can do it.
The comment was, she said, it seems odd that patient signature is not required on the POLST.
Yeah, that's there's definitely a place for the patient signature. I recognize that that on the document it doesn't say required. However, I have never seen one accepted without a patient signature. Or a healthcare proxy, should the patient not be able to sign.
It looks like William Bogley's hand is up. Do you want to?
I think it's for a high five. Hey, go ahead, William.
Okay. Hi, everybody. My name's Bill. I'm a caregiver for an ALS patient. We're already in PEG tube. We're also on passive ventilation at home 24/7 at this point. So my question on this directive form, there's reference to breathing machines, but I'm aware that there are several layers of breathing support that can be put into place. We have the sort of passive ventilation at home. Have we already implicitly said yes to all levels of breathing machines thereby, whereas something like a tracheotomy or intubation is perhaps a direction we would not want to go? And when do we make that distinction?
Yeah, that's a wonderful question. Thank you. And I like you know, these things can get so deep. So this is why I think it's so important to talk about it. But no, you have not said yes to everything. And in fact, at the end of the advance directive, there is a paragraph of just blank lines for sort of open-ended rhetoric. So you could use that section to really parse that out, which is that passive and at-home ventilation is acceptable, but continuous life support or continuous ventilation for the sole purpose of prolonging life would be against the patient's wishes. And there is a section on the POLST form as well under treatment. It's one line, which is a little frustrating sometimes, but it says additional, and that is an area too where you could make that distinction. Great questions. All right, let me plow forward here. So here is the end of the advanced directive. So remember, the terminal condition is not the only thing on there. There's pages. I just didn't include all of them because I didn't think you'd want to have to go through all that today. The end is important. So there's two sections, and you notice the red oval says either A or B. This is an Oregon thing. I don't know what it's like in other states, but at the end you need to sign it. And you need to have it witnessed by either a notary, this is the legal part, or two witnesses. And two witnesses will suffice for the legal purposes of this document in the state of Oregon. So you don't have to have it notarized for it to be legal. A couple of other key points here. This is where you do your healthcare proxy, your healthcare representative, and I would recommend having an alternative to that person. So one person and then an alternative. Because for instance, if your healthcare representative is your spouse, but you and your spouse are in the same vehicle and have an accident, then you need someone else that wasn't with you to help you with those decisions, if that makes sense.
Holly, I'm so sorry to bother you. Are you talking about the POLST or the AD at this point?
AD, this is
Thank
the
you.
advanced directive, yep. Remember on the POLST, you have a small place just for an emergency contact because that's a medical order. This is the legal part. Here's another important part of this. If you want to do your advanced directive, you don't have to fill out the whole thing. This is the most important part, is at the end. Where you designate your healthcare representative and you have it witnessed or notarized. The rest of it, if you don't feel like you can make those decisions, you don't have to actually do them. But this is the meat. This is where the money's at. So I found this from the NIH. These are things to consider when you choose your proxy. Some of them are kind of funny, I think, but am I comfortable with this person? Am I comfortable talking with this person about my wishes? Will this person honor my wishes? My partner and I like to joke that it's our 4-year-old little boy that we're going to make our healthcare proxy, and definitely not our 6-year-old, because I think probably he'd just be like, it's been a good life. We'll see you next time around. Whereas my 4-year-old actually stops to consider people's feelings. Can this person handle it? Can they handle the conflict that might arise from it? And then are they going to be around, or do they live near me? Would they travel to be with me if needed? The person that you pick doesn't really need to be medical or have a medical background. Sometimes that can be a great thing, and sometimes that can be kind of a bad thing. And so really the most important thing is that you think that they can handle it in this difficult time and that they know what you want. When might you want to change your advanced directive? Different periods of your life, you may want different things. When a loved one or that person that you've selected is not with us anymore. If you don't agree, and this, life changes us all. And so it's just periodically, just be thinking about when you might want to change this. When a divorce or annulment happens, if your medical conditions change and you have a different type of illness, or if you're starting to have a significant decline, or if the person who's your healthcare representative is having a significant decline. And so just to revisit our objectives, did we reinforce the importance of advanced care planning? Yes, we did. I'll just say that. Key differences in the advanced directive and a POLST. Advanced directive is legal. Until very recently, I would have said I thought the POLST form was the most important thing you could have because that I was practicing primarily in the hospital. If I revisit that perspective, and after numerous presentations and hearing more about this, both from the medical and legal perspective, I really think that your advanced directive is as, if not more important, and particularly because that is where you designate a healthcare proxy. That's your healthcare proxy. Those are your long-term or subacute decisions. The POLST is for an emergency. If you have died a natural death, are we trying to bring you back? And what type of immediate medical interventions do you want in those situations? And then this is from a book I swore I'd never quote because it's so heart-wrenching, and here I am. But this is a Chinese proverb from the book that I got from the book called The Overstory. It says, the best time to plant a tree was 20 years ago. The second best time is now. And with that, I will open it up and attempt to answer any more burning questions you might have. This, the one in the Christmas sweater is the one who will not be making my healthcare decisions.
I don't see any questions in the chat, but if people have questions they want to ask, they can put it in the chat or unmute themselves.
I see Megan has a hand raised. Hey, Megan.
There I am. I'm unmuted. Hi.
There we go.
Hi, thanks so much. My question is, if the advanced directive is really kind of the key one here, if you're fairly healthy right now, how do you make sure, you said that you need to get it into your medical record, but basically I'm trying to find out, how do I know that doctors, EMTs, everybody knows my wishes?
Yeah, so in Klamath Falls, we have one hospital, and that hospital and several of the clinics share a medical record called Epic, an electronic health record. Basically, your clinicians if those systems are connected, you can simply just take it to your PCP, and that office can just scan it into your record. And in most EHRs, electronic health records, there is a clear designation within the chart to your provider of end of life discussions and documents. So for you, for instance, if you brought that to me, I'd have it scanned, and then henceforth I could just click on that link and it would show me your advanced directive. If they're not connected, it may be worth taking one copy to your primary care provider and one copy to your hospital provider. I'm not actually aware of how EMS would access your advanced directive, but EMS is an emergency service and they're more likely to need your POLST form. And so what we have people do who have a POLST, which is, usually when you have more serious conditions, is to have that on their refrigerator or something on their refrigerator that tells those service providers where that would be located. And then our attorney who presented with us in the community, he takes a file folder. Of course, he's an attorney who's very organized, but when he travels, he takes a folder of medical documents with him so that if he were to encounter an issue traveling, they would be available to whomever needed them.
Okay, thank you so much.
But yeah, thanks for being here. I appreciate it.
Dr. Holly, there's two more questions. Carol asked, if my children are out of state, I can have a neighbor be my decision maker. I think she was asking that question. Then when the kids arrive, can they take over? And the second part of that was the children would be on the alternate list.
Boy, that's a good one. I am not entirely sure how that would work, because if you designate your first, and this is just a thought, and maybe Lori, we can track this question and come back to offer more sound advice, but my hunch is that you would want in that situation to put your children as your healthcare proxies first and second, your neighbor as your alternative, so that when they did arrive, there was no confusion that they were in fact who you wanted to make your decisions when they were available.
Okay. The second question was from Holly. Should POLST, she said, I don't know if this is a question or comment, POLST should send you a confirmation letter once it is entered into the system. They use to mail you a magnet for your refrigerator as well, but I don't know if they still do that. Oh, okay. So she was commenting on a former question.
Well, that'd be cool, a magnet. That sounds fun.
So Holly,
Okay.
Yes, sir.
I have a funny story about all this.
Oh, good. This is Dr. Galis, a legend here in Klamath Falls.
And by the way, I'm 80 and we just did our POLST and advanced directive. That's how bad we are. But I've always said when I'm to my 4 children at the dinner table, we've talked about it. And I said, so when I am confused, demented, don't know anything, don't know who you are, you're supposed to take me to Lakeview with a blanket and a bottle, and I'm going to walk east by myself toward Winnemucca. And the second thing I've always said, people say, well, all physicians go do golfing. And I said, no, golf to me is something to do when you're getting ready to die. And so one time I went with my youngest son to a medical meeting and they had a opportunity to go golfing and he convinced me to go golfing. So we went golfing, we got home, we were sitting at the dinner table and talking about this. And my oldest son said, Dad, you went golfing? Are we supposed to take you to Lakeview? So we joke about it, but it's no joke. And it's really an important thing to have. Unfortunately, I think you said, well, you're not going to say whether you have your advance, but we delay it. We deny it. The other thing is if you're at all getting older and thinking about, retirement and providing for your family or your children, if you do for your tax purposes, a trust, they're going to require that you have both an advanced directive and a POLST form. So it's another reason to do it, and a whole lot better to do it early than dumb people like me who wait and drag your feet, So anyway, just some words of advice.
Yeah, and just full disclaimer, you did not hear from me to get a bottle of whiskey and head out into the cold by Lakeview. That was from Dr. Galis, not
That's
Dr. Montjoy.
So
Well,
go ahead.
oh yeah, go ahead.
Well, so it sounds like you could have a POLST if you were healthy and you didn't have a medical emergency. So now I'm a little confused about the POLST. I thought it was only if you were, something happened.
You can have it earlier, and sometimes if you go in the hospital, they'll have you fill one out. It's more just so that there's documentation that, let's say something happened to you, let's say you went in for a surgery for your gallbladder and something happened because of anesthesia and they wanted it documented that you wanted to be full code or DNR. However, it really truly is intended for patients who are seriously ill or medically very fragile. So that's not the intention of the POLST, although sometimes we get it wrong in healthcare, but the intention is not for everyone. I know that you all could have been doing different things today, and I just I appreciate your time. I appreciate your forethought into these things, and I think it's wonderful what you're doing for yourselves and for those around you. So have a great rest of your week.
Thank you so much.
Thank
to our presenters.
you. Thanks very much.
This was terrific. Well done.
Thank you.
Dr. Holly Montjoy, we'd like to thank you for being our presenter today. This has been very informative. Please keep an eye out for an email within the next 2 days containing the recording of today's presentation and information on the next part of our series, which will take place next Thursday, January 18th at 1 p.m. Also, I would like to thank once again the Oregon Nonprofit Hospice Alliance for sponsoring this free talk. And thank you to all of you for being here. Have a great day.
Thank you.